Fantastic. All right, we see your slides, and I think we have reached a quorum. So let's go ahead and get started because I know this will be an exciting presentation with tons of questions at the end. So we are so excited to welcome you all to Department of Medicine Grand Rounds. I'm pinch hitting for Wendy Armstrong today, who is on vacation, and will be missing an extraordinary presentation with Amaka Ananya, who is currently our Chief Transformation Officer at Emory Healthcare. And the goal of the Transformation Office is to optimize patient experiences from end to end, which includes improving patient access, patient customer service, health equity, and clinician and staff well-being. So no small task. And prior to this, she was head of strategy and operations at the Global Medical Office for Fresenius Medical Care, which is a global dialysis company. Dr. Ananya graduated cum laude with a bachelor's degree in sociology from Cornell. She has a medical degree with honors from Meharry Medical College, an MPH from the Harvard T.H. Chan School of Public Health. She completed her internal medicine residency at Brigham and Women's Hospital, followed by nephrology training at Mass General Brigham and Women's. And her research and clinical interests center on healthcare delivery and health equity. Her most notable scholarship resulted in a change in national and international standards for lab reporting for individuals with chronic kidney disease or at risk for chronic kidney disease. And this work has been heavily cited in all of the academic journals. We have all read these papers in the New England Journal, in JAMA, and also discussed in New York Times, NPR, and in all of our local journal clubs as well. She's also worked with several political leaders and policy committees to create federal policies to ensure changes to clinical standards are centered in health equity and that they are sustainable. In 2020, she was recognized as a 40 under 40 leader in minority health by the National Minority Quality Forum. And in 2021, she received the Radhika Srinivasan Award for Humanism and Professionalism from the Department of Medicine at the University of Pennsylvania. It is my absolute pleasure to welcome you here today. Thank you so much for being here.
Thank you so much, Karen. And it's great to be back at Emory, like literally back at Emory, because I was here, I think 1 year ago. Dr. Manning invited me. And so good to see you all again, and happy to be part of the family now. Just a quick, I'm seeing a lot of admit into the waiting room. I'm just going to ignore that because other people are admitting, I'm assuming, Karen. Okay, excellent. So let's move forward. So today I'll be talking about transformation in general in healthcare and what that looks like. And then kind of using some change transformation principles, walk everybody through how transformation occurred in the field of nephrology and really the field of medicine by changing how we use racialized algorithms. And then I'll end on the transformation initiatives at Emory Healthcare and kind of what's going on. And I'm hoping that will prompt a lot of discussion and engagement. So let's talk about transformation in healthcare. So the number one question that I continue to get 10 months in is, what is a chief transformation officer? Well, essentially, it's a new C-suite role. It's a new industry role, not just in healthcare, but it's really someone who's brought on to do cross-functional complex initiatives, push against the status quo, garner excitement to do whatever the organization has deemed deemed a priority at the time. And so really, at EHC, the goal is to advance these ambitious enterprise-wide objectives that would not be able to be achieved through incremental change, and to build muscles around transformation, right? So do it once, great, do it again, and then it becomes something that can be done in a sustainable manner, that initiatives can be rapidly transformed, right? Using the employees that we have here, processes, technologies, but using all of those to do disruptive change. So many of you may have heard of John Kotter, a Harvard Business School professor who's published a lot on organizational transformation. And he says that there's 8 key steps to transforming an organization. The first step is establishing a sense of urgency. And this is probably the most critical step that he has found to be, if it's skipped, your transformation will fail. And when we're establishing a sense of urgency, we're looking at the market, right? Looking at competitive advantages and disadvantages, identifying potential crises, right? Thinking of areas of opportunity. And then you want to move to forming this powerful guiding coalition. So find that powerful team. And that's just not at the top, right? I think it really involves the middle management, but the frontline team is really where you need to be thinking about, and also the community. So thinking about the community stakeholders, our frontline employees, to build that powerful coalition that's going to carry out that change that you're envisioning. And then you want to create the vision, right? That's the strategic plan, right? Coming up with your strategic initiatives and objectives. Once you've created that vision, you want to communicate that vision and using all channels. So whether that's email, which to me is not as powerful, but in person. So town halls, doing rounds, getting out there in the community, going to these events and communicating that vision and using that powerful coalition that you've just formed to also communicate that vision, right? Kind of leading by example. And then you want to empower others to act on the vision. And this is also a critical piece. So you want to get rid of obstacles, right? Changing any systems or processes that are obstructing that vision. You want to encourage bold risk taking in this part of the transformation, and making sure again that you're supporting those individuals that are doing that. And then here's the fun part. You want to plan for and create those short-term wins, right? So you want to show the visible performance improvements. You want to recognize those employees that have helped you get to this point so far and make sure that they are, again, communicating that continuously as they're performing that change. And then you want to consolidate the improvements and produce more change. So now you have some credibility. You've done the quick wins, right? You've changed the structure. You've promoted individuals that are helping you, this coalition, and you want to continue with this process over and over again. This is the muscle building, right? You're making these improvements, you're referencing what you've done before, and continuing to do that. And then lastly, you want to institutionalize those new approaches. This is the sustainability piece of transformation. So you want to make those connections that you've done with those quick wins, those long-term wins, the success of the business or the corporation. And then you want to also think about succession planning, right? The structures that you've created, they have to make sense. I think too often we are wanting to give opportunities to those who we like or who may be good at what they do, but what happens when they leave, right? And so you want to make sure that the structures are in place and that you have clear leadership planning, leadership succession planning for this transformation to actually stick, because it can be reversed and it has been reversed. And John Cotter talks about that explicitly. So I would encourage everyone to read his book, What Leaders Know. It's a quick read, it's excellent, and it talks about this in great detail. So let's talk about lessons learned from nephrology transformation and how I could apply these change transformation principles to change the field of nephrology. So first, let's just think about the previous state of affairs. For those who attended my grand rounds, it was a year or two ago, and I think it was 2 years ago. What we had in nephrology was the following. Imagine a Black person walks into a clinic, a nephrology clinic or primary care clinic, and a non-Black person. They're the same age, the same sex, they have the same serum biomarker, right? Their serum creatinine is 1.7, but their eGFR equation, the equation that we use to diagnose and manage kidney disease, differs by a magnitude of about 16%. So that Black person has a higher eGFR compared to that non-Black person. And how we would say this in layman's terms is your kidneys are working at about 47%, right? And so just off of the basis of skin color, that Black person has healthier kidneys compared to a non-Black person. And so we've talked about this before, but many reasons why we got to this state, but let's talk about the downsides of having that Black race equation implemented in care. So we have national and international guidelines that say when a patient can be referred for instance, nephrology specialty care to see someone like myself. And that recommendation is to refer somebody once their GFR is less than 30. We also know that you can get listed on the kidney transplant list when your GFR or eGFR, most people use, is equal to or less than 20. So you can imagine, first of all, we have existing disparities for Black individuals in particular who are afflicted more with kidney disease based on a higher prevalence of comorbidities such as hypertension and diabetes. So there's already existing epidemiology for patients who have CKD, skewed epidemiology, and now they have to wait longer to see a specialist and wait longer to get their kidney transplant waitlist time based on this race-based equation. There's also a delay in referral for kidney failure care. Kidney failure has become the new term for end-stage renal disease. And so the nomenclature has changed, but that's basically preparing for dialysis. And there have been decades long of national initiatives that say, fistula first, or making sure that your patient has enough education, is engaging in shared decision-making with their clinician and their families, early in the process so they can decide, is it dialysis for me? Is it a fistula? Or maybe it's a catheter? Is it peritoneal dialysis? Is it no dialysis, right? Is it more of a palliative care approach? And Black individuals in particular are delayed for this care. We can have improper dosing of pharmacologic treatments. Obviously, if you're seen as having healthier kidneys, you're going to get higher doses of medication. There's no accommodation for patients of mixed race and ethnicity. What do you do if President Barack Obama walks into the clinic or Vice President Kamala Harris walks into the clinic? How do you treat them, right? Because there's only two equations, Black and non-Black. What do you choose? There was an individual that I knew of in Philadelphia who was Black, phenotypically looked Black, identified as a Black woman, had one white parent and one Black parent. She asked her transplant physician, can I use my white side to get listed earlier? They let her do it because we don't have an accommodation for patients of mixed race and ethnicity. And obviously, there's a lack of transparency with patients because we're not letting them know about this race-based algorithm that is really truly dictating their care and the timing of a lot of these critical referrals. And so establishing a sense of urgency was a big piece of this. Some had written about this prior to this JAMA editorial that my colleagues and I at University of Pennsylvania wrote about, but nothing in a high level academic publication. And this went viral, right? Really challenging the premise of a race-based algorithm, one of many in medicine, by the way. It got a lot of attention. And so establishing a sense of urgency that this is wrong, that this is widening disparities potentially. We've never studied it, but this likely is widening disparities that exist in nephrology and in primary care. And so we need to do something about it, right? We need to rethink how we're doing this. And then we had to form this guiding coalition. So overnight, right, I became the spokesperson for EGFR equations, which is a very different science. I was funded as a patient reported outcomes researcher in the nephrology space. So palliative care and health equity was my jam, not measuring GFR in thousands of participants who have kidney disease or normal kidney function, and then doing high-level statistical models to determine EGFR equations, right? And so myself, I could not do this. And so I had to collaborate with leaders from all over, from academic medical centers, chairs, chiefs, hospital lab leaders, chief medical officers, people who were really dictating changes in the laboratory, academic journals, academic societies, federal policymakers. I presented to the Ways and Means Committee. I talked to Elizabeth Warren's staff, who was really interested in racialized devices, right, like PFTs and pulse oximeters. Governors, senators, the media, they were really my friend in all of this because they were so outstanding. They were so surprised that we were using this algorithm and they wanted to write about it. They were eager to write about it. But I really could not have done any of this work without medical students and trainees. And I think we're seeing some movements right now, right? But medical students and trainees are very powerful. And so I would actually call them, you know, our front line, right, in terms of a lot of our academic initiatives, but they were challenging their professors across the country, challenging their deans, hospital leaders, lab leaders about why we were using this. And that really made a big difference. So when I talked about that forming the powerful coalition again, focusing on the top would not have been a good move. And John Cotter also has talked about this. And then we had to create the vision, right? What would this look like with a different equation? And from the academy, we were getting a lot of requests of, oh, this is anecdotal, right? Like, how do you know that your approach is right? And so we had to really use, you know, a lot of the research that had been published outside of medicine, anthropology research, sociology research, bring that into the discussion, and then use that to academically critique a lot of the research that had been published and was continuing to be published. We saw some race-based things during the pandemic, right, in terms of COVID affecting different racial groups, et cetera. We had to collaborate. Specifically, I had to collaborate with the original researchers who had access to, again, thousands of urine and blood collections to measure GFR. That is how you do an eGFR equation. It's an estimate of GFR. I did not have that data, but the original researchers did. They didn't have access to a lot of the health equity information that I knew about, right? And so I had to come together with those individuals to create, what would a new research paper look like? Right? What would it look like if we implemented a new equation without race? How would that statistically change the performance of an equation? And how would that change the epidemiology of kidney disease for our country? We had to produce new data and then create this scientific dissemination and media strategy. And then we had to communicate and empower others. And I used every tool in the box, right? Considered a geriatric millennial. So I went on TikTok and that video went viral on Twitter, like 30,000 views. It was all over the place, being referenced in a lot of TikTok videos as well. Because the reason I was doing that was because a lot of the academy did not agree with this change. They felt it was anecdotal. They called it woke medicine, et cetera. And so using the media, using social media, again, using grand rounds, different industry talks that I did was a way to communicate this vision of, hey, we need a new way. This is wrong to move forward. Also partnered with Grey's Anatomy, their writers. They did an episode on this to get that information out there to our patients, right? The people who were really being affected by this equation who had no knowledge about it. And this was a way to communicate that vision. Then we had to plan for it and create the short-term wins, right? So I was honored to serve on the National Kidney Foundation and American Society of Nephrology Task Force. We convened based on all the political pressure that they were receiving. The societies saw what was going on in the journals, saw what was going on social media, and said, hey, we need to do something about this. And so we had to come together to think about the national recommendations that we would make if we had new data, reviewing all of the data, having different stakeholders from across the globe with different expertise come in to talk about what that win could look like. We also had patients on this committee, which helped to bring down the ego in the room. Very powerful to be on this task force to plan for that short-term win, the short-term win being the recommendation, as well as the long-term win, right? How could we lobby for more funding to look at this space, right? Knowing that an equation was not going to end health inequities in nephrology. And then we had to consolidate the improvements and produce that change. So I was honored to be a second author on this New England Journal of Medicine paper that published the new race-neutral EGFR equation without race that could be applied broadly to everybody. This was the national recommendation that we made for the task force. And so we were able to show everybody the quick win, right? Show other societies, and they quickly started to change their racialized algorithms. So this is the building muscle piece, right? You're able to demonstrate how that change has happened, and other people quickly catch on. And then you want to institutionalize the new approaches. And so how do we codify this? What is our sustainability plan? And that to me was policy. So when we had that national recommendation, but then a number of federal policies that I was honored to work on have happened since then. So I serve on the Minority Affairs Committee for the United Network for Organ Sharing. The first policy that came out was in June 2022 that said that no, out of the 230 US transplant centers, all of them are prohibited from using any race-based equation to list any of their individuals for kidney transplant. So you have to use a non-race-based equation or something like a creatinine clearance, 24-hour urine collection, or GFR, direct measurement of GFR, which is a little bit more challenging. The next policy to me was the most impactful, and a lot of the press has picked up on this more recently, but this was in January of 2023, where UNOS said that all US transplant centers were required to review all of their Black patients on the kidney transplant waitlist and then modify the waitlist time if a race-based equation was used, and they could have gotten more waitlist time or waitlisted sooner if a non-race-based algorithm was used. And so we just released our annual report, our 1-year report, and that's why a lot of the press has picked up on this. But 14,500 Black patients had their wait time modified. A median time of 1.7 years was given back to patients. Some of them had gotten multiple years, 5 years, some even 10 years back on their transplant waitlist time. And as of December 2023, 2,867 Black patients had received either a deceased donor transplant or a living transplant. And so really powerful ways to sustain this work is to make sure that we can go and help the patients that were affected by these policies. And again, to make sure that this does not happen again. The third policy, which has just come back from public review, will be taking out race from one of the organ tools that is used to grade organs and say whether they are suitable for a transplant or not, and that's called the KDPI tool. That also has a race variable that we have analyzed in UNOS. We had some experts come in, reanalyze that data to show that a race neutral predictor actually performed just as well as the one with race. And so that is at the board level now for UNOS approval. And once that has been approved, then we will no longer have any race-based algorithms that will affect our decisions about whether to use an organ from a Black individual or not. And so really powerful ways to institutionalize these new approaches, again, all using John Cotter's change transformation principles. So let's switch gears and talk about transformation at Emory Healthcare and what's going on. Lots of work to do, but I think we're doing a lot of good and exciting work that I'm happy to share. So let's talk about first our patient population and where they're coming from in the greater Atlanta area. So our primary service area are these 6 counties that you see here: Clayton, Cobb, DeKalb, Fulton, Gwinnett, and Henry. And then we have our secondary service area, which are these 6 counties, followed by our tertiary service area, these 22 counties. So you can see that our primary and our secondary service area total about 83.4% of the population, whereas we have a smaller percentage from our tertiary service areas and other parts of Georgia. We have a very small international population and hoping to change that over time, given that Emory is such a powerhouse for many of the public health initiatives that have happened in this nation, a lot of the infectious disease work, et cetera. And so really hoping that this can change over time as well. And so our healthcare population demographics are as follows. As you can see, we have a population that is quite diverse, which actually matches our employee base quite well, but we serve African Americans 40%, 38% Caucasian, other multiracial are 19%, and then the remainder are our Asian Pacific Islander population. And we see some variation based on the hospital that these patients are being discharged from or where they're being seen for their clinic appointments. So as you can see, we have a larger proportion of Caucasian patients that are seen at, for instance, St. Joe's and Johns Creek, and a larger proportion of Black patients who are treated at Emory Hillendale, as well as our Decatur Hospital. We also have larger proportions of Asian populations at Johns Creek, and you can see the breakdown of other multiracial groups. So we have quite a diverse patient population. We also have some variation with our age or average age of patients. And so when we're thinking about the initiatives that we need to carry forward to improve patient experiences, we need to keep this in mind, right? It's not going to be a one-size-fit-all initiative. It will have to be nuanced. It will have to have health equity centered. And we will need to be partnering with our communities that are coming from these different patient demographic groups. So let's talk about, if we're thinking about transforming patient experiences from end to end, the initiatives that our health system has set currently, we have to look at how we are perceived. And so working with Deloitte, we were able to do this market analysis of how, for instance, patients view their ease of getting to care, and once they're into care, how is that experience, and then also the community. So looking at our website difficulty score, I've heard this multiple times. People do not find that it's easy to navigate our Emory Healthcare page, to find their clinician, to make their appointment. We were given a website difficulty score of 24% compared to a national average of 6, or compared to our local competitors of 16%. Our attraction score for our brand was that we have a pretty good brand despite this, right? 39% compared to 17% for Northside. However, when patients are talking about would they use Emory for every situation, and whether Emory perceives, whether they perceive us to be a well-oiled kind of coordinated machine, we're ranked lower than our competitors. So Emory patients perceive at 60% that we act like a well-coordinated system, compared to Piedmont at 64%, Wellstar at 71%, and Northside at 73%. We also see that in terms of community, that we don't have the same type of perception in terms of how we're being seen as being a strong community partner. So for Emory, it's 69% compared to 78 for Piedmont, 73 for Wellstar, 69% for Northside. And Wellstar and Grady were observed as having a publicized health equity center. And although we have numerous, I would say voluminous health equity activities across Emory Healthcare and the School of Medicine, we are not seen on the outside as having a coordinated health equity effort. And I know that that's ongoing work that many of us are working to improve. So Emory's transformation office vision and ambition is to create this one Emory standard for seamless and accessible experiences where we can achieve equitable care outcomes. We can only do this by working cross-functionally with individuals outside of transformation. Obviously, again, transformation is this dynamic office, right? There's nothing that's going to be in this office that can happen without our partners in PGP and HR and digital, et cetera. And so we need to do this cross-functional collaboration to do what's best for our patients and our systems. And what we really want to do is, again, create these seamless pathways to care, respecting patients' times and their priorities, showing up for as a unified system, not making patients bounce around to get their mammogram one place and get their follow-up at this place, providing care beyond Emory's physical footprint. So making sure that they have easy, seamless care if they want to leave our healthcare system. But also keeping in mind that whatever we need to do can't negatively affect our clinician and staffs. So making sure that we're fostering this culture of well-being, that we're triangulating our employee experiences with our patient experiences and enabling this service excellent mindset and making sure that our clinicians are able to work at the top of their license, not being burdened with administrative tasks or being the social worker, right? That we can resource them and then make sure that they can work smarter and not harder to really make sure that we can achieve these optimized patient experiences. So the ETA guiding principles of transformation are such. Equity, transparency, and accountability. So equity, I've said that multiple times on this during this presentation, but making sure that no one in the community is left behind, but also again, including the voices of all of you, of all of our employees and staff to make sure that they are also putting input or making suggestions about the initiatives that come out of transformation. Transparency. When I was interviewing for this position, I was hearing from all over the place that EHC has a reputation of doing these top-down decisions, right? That we're not transparent with the data that's driving our decisions, that we're not walking around and again, showing everyone what we're doing. It's kind of like you get an email or you get some mandate and that's what it is. And that has to change. And so the transformation office will be using data to drive our decision-making and sharing that openly with everybody. Dashboards, reports, whatever you need, we will provide. If we have it, we will provide it to you. But with that, there needs to be accountability. So we're making sure we're including those voices. We're showing people the data that we're using to make decisions. Then we need to hold individuals accountable for that change. If they can't do that change, we need to know why and we need to resource them, right? But if it's not a resource thing and it's a mindset thing, I also need to understand that. Why are we not moving forward with some of this much needed change? So accountability is also a big part of the guiding principles. And as I've already mentioned before, we serve to cross-collaborate across the enterprise. And so the 5 key priority areas that have been called out initially for transformation are as follows: patient access, patient experience, health equity, workforce experience, and business transformation. So patient access, many of you have heard of Emory Now, and I'll talk about that in a second, but we want to improve new and existing patients' abilities to access Emory services in a timely manner. Also thinking about costs, right? So this is the first state that I've worked in that does not have Medicaid expansion, but what does this look like for the underserved patient population? How can we partner with community health centers and make sure, again, that all patients have access to new and existing appointment time? And then there's a patient experience, and this is the customer service aspect of patient experience. And if for those who were lucky to attend the fireside chat with the CEO of Coca-Cola and Ravi last week, he mentioned this, right? Consumerism is really where we need to be focused, not our market competitors, not really focused on exactly what they're doing. What are our patients saying, right? What is the service? What is the communication that they're receiving here when they're getting their care? What type of digital technology can help with that experience, right? Making it easier for them, making sure that we're training them on that digital technology and keeping them informed to make sure they navigate their care much better here. Health equity, I've spoken about that several times, and I will say that this is an area of the largest opportunity for Emory Healthcare. For too long, we have so many amazing faculty that are doing work at Grady, and we've put that onto Grady. That's not right, right? we all need to be invested. We all need to be invested in health equity. That is everybody's job, moving from sick care to well care, and in building out those partnerships with our community stakeholders and our community individuals to make sure that this is the wraparound services that patients need are available. And there's a workforce experience, and not necessarily the engagement piece that HR really owns with our pulse surveys, but the burnout and the focusing on the rote work, right? The pain points that are affecting our livelihood. We can't do any of what I've mentioned if we have our employee and staff base who have poor well-being. And so fostering a culture of respect and resiliency, and again, workplace efficiency is really the goal of transformation. And then lastly, business transformation, which is the effector arm of transformation. So they are the ones that are setting up governance processes, doing value stream analysis for really complicated, complex things that cannot be done again incrementally. They're seen as a kind of our internal consultants, right? They identify the issue, they look at all the data, they come up with the project plan, they set up the governance committees, and then they execute. And then they also come up with the KPIs, right? Our key performance indicators to make sure that we are measuring success and tracking success over time. So let's do a deep dive into some of the exciting things that have happened in these transformation office functions. So patient access, I'll start with. Many of you have heard of Emory Now, the initiative that was launched about a year ago, a little bit over a year ago, where we ask when patients call in, do you want to be seen today, tomorrow, or in 2 months? We have different options for patients to schedule online, whether it's their clinic appointment or their diagnostic radiology test that needs to be done, and for them to have extended communication with the contact center. So extending the hours of the contact center to go beyond banking hours was a big part of Emory Now. And I will say that despite a lot of hesitation and maybe some trepidation about what this would do to our clinicians and staff specifically, it went incredibly well. We had a big increase in patient arrivals, right? And so an 8% increase in the arrived minutes. This is all patients established and new. And then we had a 10.5% increase in new patient arrivals. And in my discussions, when I had my listening tour in the fall specific to patient access, was that for the most part, I'm not saying it's perfect, there were some kinks, but for the most part, this was well received, right? And we had opportunity to increase, to open our doors a bit wider to serve our patient population. And so huge success from Emory Now, a great investment that gave us a lot of return beyond the financial piece, right? Patient experience, our clinicians and staff liked it. And we really had to firm up a lot of our tech stuff, our Epic implementation piece, and that was also well received as a part of this. So success for Emory Now, unless you tell me otherwise. I see some things popping up in the chat. Self-scheduling was also a big success. So in Q4 of 2022, we had less than 2% we had 1.7% in Q1 of 2023 of patients scheduling their appointments online. That is now 6%, so we've seen a great increase. We are in the top decile for academic medical centers who have available appointments online. So we have 32% of our appointments online, but we're only using about 6%. So we have opportunities to improve there. And we just met and put our heads together about how we can tackle a socialization strategy with our patients, how we can give them more support, right? What does that customer service aspect look like when they're coming to our clinics or doing their virtual appointments? How could we get them onto these platforms if they have those capabilities to do that? So they don't have to call. And again, that's only if the patients want to. A lot of our patients do prefer phone, and we understand why that is, but we do have some opportunity here. And we also know that we can now schedule in 30 of our outpatient specialties and 10 of our diagnostic modalities. So again, huge leaps and bounds from Emory Now. I also want to call out some of our access is extremely restricted, and these are national issues, right? There is a national shortage of neurologists. There is a national shortage of psychiatry clinicians. And so really leaning on our Emory Healthcare Network in the meantime, as we build up more capacity in-house, is a big goal of the Access Center. And so partnering with our EHN, our Emory Healthcare Care Clinically Integrated Network is something that we've done over the last few months. A lot of the providers, these private practice clinicians, have actually trained at Emory, have very good relationships with a lot of you. And so we leaned in on our clinicians at Emory and said, who do you want to work with? Who do you trust? And if you're jammed up for at least 2 months, right, can we then refer out and make it seamless for our patients? And we're starting with our neurology or our dermatology pilot any day now. We firmed up the processes so we can actually make the appointment for the patient, right? Again, seamless when they call in. If we don't have it, if they don't want to wait for our availability, or they have a diagnosis that they think could be easily managed in the Emory Healthcare Network, we are offering this to them. Again, meeting them where they're at. So what's next? Bundled ticket scheduling. So ticket is a fancy word, fancy tech word for orders. So when an order is placed for a patient to have imaging and a clinic appointment, we are looking at this in OrthoSpine now. How can a patient be able to schedule that right away, right? In a one-stop shop through MyChart. We are doing that now, and so far it's going well. There's a self-arrival that we're launching now. And self-arrival means that you'll be able to check in very similar to your CVS Minute Clinic appointment in your car, right? Be able to bypass the front desk, have all of your questionnaires when you're doing your e-check-in, all taken care of. It will use your location to check you in. And when you're ready to walk in, you can go ahead and do that. And so looking to do that. And if we do that, then we can repurpose our front desk staff to, again, be more customer service. How can I help patients who may have some disabilities? What is the scripting that we can use to improve communication? No more clipboards, no more faxing, and no more copying of your license, which I don't even think is needed now. But we have these technology capabilities. And then also we have a lot of opportunity for virtual care. We are seeing about 9% of our ambulatory clinics, our ambulatory appointments as virtual care appointments. We have opportunities to do more of that, to do things like e-consults, so clinician to clinician messaging that can be built for e-visits, where patients can do structured questionnaires. The patient and the clinician can respond to those questions with messages or with prescriptions, the treatment plan, and that is the visit. You're done. You can bill for it. And that can also open up more space for people who actually really need to be seen in person. And so we're doing some of that in pockets. We have opportunities to do a lot more compared to some of our peer academic medical centers. Patient experience. We're doing a lot of work here with structuring. What I found here was that all of our operating units and the PGP, right, our physician group practice, all had different components of their patient experience team. So they had their patient facing teams, the patient experience, when some hospitals have the gift shop reporting up to the directors of patient experience. Some have guest and volunteer services, some don't. And so really harmonizing all of these entities to report up centrally to a VP of patient experience is something that we are doing now. We have an interim VP of patient experience who is actually the current director of Emory St. Joseph's patient experience, and she's doing a fantastic job while we look for that national leader who can come in and we can think about the standard work processes, how we're going to hold individuals accountable, the care team consultancies in terms of the scripting that patients that have been proven to help with patients' experience. A lot of that work is being done. And then we have a lot of our analytics, our press gaining analytics during our service performance team. This has never existed prior to transformation. We had a service performance team and again, these silos. And so harmonizing this structure is something that we have worked on and we're continuing to work on. And we have different patient-facing individuals. So we have our experienced consultants that partner with our care teams and think about the rounding, bedside shift report. Are we doing this with our patients? How are we introducing ourselves with our patients? So we have, this is a very powerful position in terms of our balance scorecard and those scores that we're seeing. We have our liaisons that are the patient-facing individuals that are checking in about discharge instructions, checking to see if they need an additional blanket, right? Making sure that all of their questions are being asked. And we have this patient advocate who are really doing a lot of our service recovery, following up on complaints, making sure those complaints don't turn into grievances, and closing those out in a timely manner so that we are in compliance with CMS and other regulatory bodies. We are doing a hard look at these positions now and making sure, again, that based on the needs of each operating unit in our, we are we are meeting the needs of our patients and our care teams. This is our balance scorecard. And what is this? These are the scores of patients who would recommend the hospital that they're getting their care at to their family members or other individuals. And so we know that the driver of these scores, which are on our leadership and executive compensation plans, are really the care team interactions with our patients. And so you'll see in green, in March, we are meeting a lot of these targets that have been set to us by HCAHPS, but we are also below, right, in some areas, and we are quickly and nimbly resourcing these individuals or these entities or units that may need help with their patient satisfaction scores. But we have seen a remarkable improvement since September to now in terms of these thresholds and meeting target. We released our inpatient press gaining dashboard so anyone can log on and see exactly how patients are rating themselves, rating their teams, their units. We also have that on the outpatient side. So you can see based on your clinic, what patients are saying about you specifically or your department. And so again, increasing that visualization of data and transparency is the goal of transformation. Prior to this, we were doing a lot of PDF emails, manual requests and manual pulls. No longer. You can all log in. This is all through Epic and access these scores, whether you're on the inpatient side or the outpatient side. So what's next? We just signed a contract with a vendor called Gozio. The My Chart will become a My Emory app, and it'll just be pulling in all of these different capabilities right now into a one-stop shop. So you can do your provider search, you can do your scheduling, wayfinding, on-demand telehealth, all of that in one application. So we're super excited, and that should launch by the fall. We're thinking about videos. We have capabilities for patients to leave video feedback, right? That's always more powerful than reading it and hearing what a patient has to say about their experience. And so thinking about how best to operationalize that is on the roadmap. We want to consolidate and streamline our patient messaging as all of this tech is coming on board. We don't want patients to be inundated by multiple notifications and reminders. We want the messaging to be appropriate for all health literacy levels. And so we have a dedicated corporate director who is working on all of this and working closely with marketing and communications. And then we have a lot of work to do for service recovery and grievances. We have backlogs, several hundred backlogs at certain hospitals. We want to make sure that we are, number one, in compliance, but two, more importantly, meeting patients where they're at. If they have an issue, we need to respond quickly. And so we're firming up our standard work processes, again, holding those individuals accountable to make sure that that's done quickly. Health equity, I'm going to speed through because I know I'm running out of time. We developed, a group of us at EHC developed this commitment to health equity. You can find it on the healthcare site, but essentially doubling down on healthcare is a fundamental human right, and that no one should receive or experience any discrimination just based on who they are or where they're from. And so being committed to this and working with our communities and employee base is something that at the highest level, we are committed here at Emory Healthcare and making sure that we can operationalize this across our enterprise. We have just hired an inaugural VP of Health Equity, Dr. Brian Hunter. He has been doing this for his entire career. He will be focused on community engagement, population health management, a lot of our data processes, stratifying that, looking for health equity gaps, and then community health. I think we do a great job with branding. We're out there doing screens. We can do a lot more with a lot of our partnerships. Thinking about community health worker pipeline programs is something that we're building out. The nursing school has a certificate program for community health workers, and building out that pipeline so that those community health workers can receive their 80 hours of training in our clinics, in our hospitals, and then have job placement is something that the Health Equity Office will be leading along with case management. So very excited that Byron is about 2 months in, and I think he might be the most popular member of my team so far because people have been waiting for this, is what I've been told. And so in terms of health equity updates, we have a health equity steering committee that we're looking to review the membership and making sure that we have a charter to move forward on initiatives. We are doing a pretty good job with race, ethnicity, and age data collection. We have opportunities to do better with SOGI, so our sexual orientation and gender identity um, data collection, as well as our SDOH collection, which we pretty much just operationalize on the inpatient side in January, and we're working on our outpatient work streams now. So what's next? We have this community health worker pipeline program that I talked about. We are really passionate about making sure that the individuals that are doing the work, the 80% of health outcomes that are due to factors outside of the healthcare system, are lie in the community. And we want to give that money to those individuals where the money needs to go. We can only do so much as a healthcare system. So thinking about the partnerships and how we operationalize that is a top priority. Rural care is also a top priority. Digital interpretation capabilities, all forthcoming. And then looking at our health outcomes, disease-specific dashboards, hemoglobin A1C, CKD, proteinuria, all of that is forthcoming. And I've had a lot of our societies reach out to me about what are we doing here? And we're really just still in the beginning stages of getting these things validated and set up so you all have visualization of that data. Business transformation, again, is the effector arm. They do a lot of this cross-functional alignment. They set up work streams. They do these very complex interventions. One of that being length of stay work. So the business transformation team launched the length of stay work at St. Joseph's Hospital in 2022. At EUH, it was initiated in January 2023, and they're currently at Midtown. You can see the cost savings that have occurred because of the excess days reductions done at these hospitals. And so they get in there, they work with the teams, they do the training, they focus a lot on care progression rounds, ICU transfers, et cetera. And then the business transformation comes up with a sustainability plan, and they remove themselves and go on to the next initiative. So really proud of the work that they're doing there. Great work for our patients and our healthcare teams. And so there's also the patient experience project that was launched in October. We at EUH, we were bottom 3%, and at Midtown, we were bottom 1% based on our Press Ganey metrics in terms of patient experience and their likelihood to recommend. The business transformation team got in there, set up a project team of 40 plus individuals, nursing colleagues, operations, registration, our patient experience teams, the different scripting, our workflow, right? The flow of how people are seen in the emergency room. And I will say that we had the highest rating at Midtown at 59% from a baseline of 39% when we started. So that was the highest that they've seen since 2021. And we've also had some really good results at EUH. And so again, getting in there, that cross-functional focus. We're also focused on case management, community health workers, more to come on this, but to be in the bottom 1% and 3% in the nation was really bad. And June basically told us to get it together. So that's what we did. So that's a lot of the work from the business transformation team. What's coming? We're doing a lot of help with the PGP and working with them to redesign our clinical GI operations. They will be helping with our virtual care strategy, as well as the organization and transformation of our prioritization of our transformation initiatives using some AI tools to make it easy for everyone to see the metrics, and what we're working on in transformation is all forthcoming. And then last but not least, there's MWell. We did our strategic plan, MWell being the center that's focused on well-being for our clinician and staff members. We want to be a national leader in this, and not only what we're doing for Emory Healthcare, but our research and how we're leading in our collaborations and initiatives. And so, and also showing a return on investment. And we know that that's there. People don't like to talk about it, but we know that burnout has a financial cost. And so showing that ROI on our initiatives is part of the strategy. So I want to show this three-pronged model for well-being that comes from Stanford. There's a culture of wellness and efficiency of practice and personal resilience. We know that personal resilience is great, right? But that is not what's driving burnout. It's the culture, right? Our benefits. It's our efficiency of practice. What are we doing that's super inefficient and taking away from our well-being? That is what MWell will be focused on. These two areas. Healthy Emory has got a great hold on personal resilience. A lot of the programs that they do, and they also partner closely with us for the culture of wellness and our benefits, but lots of opportunity here, especially harmonizing that between the university and the healthcare side. We have our wellness microgrants that we did last year. Lots of great ideas that came from all of you in terms of how we can improve well-being in your specific areas, and looking to learn from that so we can launch that, and perhaps have enterprise-wide initiatives that come again from me, all of you. Will be doing that next round this year. And our burnout survey. So we were the largest enterprise to roll out this validated burnout survey. We had a response rate of about 24%. And this just measured professional fulfillment and burnout using a holistic survey. So what are we going to do with that information next? Well, we're going to do this Get Rid of Stupid Stuff Gross Initiative. It was published in the New England Journal of Medicine. It was really focused on IT, things that IT could bring to help improve efficiency of workplace, right? But we want everyone to tell us. So we actually took the top quartile or top percentage of burnout scores in those areas. We developed QR codes. It's going to be anonymous, and people will tell us what is stupid. What can we get rid of? There's going to be a range of things that are low hanging fruit to more expensive things, but that is what we need, right? We need to source that out, and again, bring that up to the leadership and make sure that we get rid of it and make that information available for all of you in your different clinical areas, because we have those surveys. And we're going to recruit an MWell chief of well-being. We have a co-chief now. There will be one chief of well-being that's coming to really lead MWell's efforts, and we'll have more individuals who we will hire to help that chief of well-being lead MWell. We want to socialize and implement our strategic plan, and again, develop a travel grant program to support attendance at well-being conferences for anyone who wants to apply. So in conclusion, successful transformation in healthcare is continuous and non-incremental, and really showing those quick wins, right? Gaining that credibility and building the muscle. Again, it's a dynamic transformation. It marches in and it marches out, is key to sustainability, as well as the succession planning. That is such a key part of this. So once things march out of transformation, the structure has to be sound, the leadership has to be sound, or all of this will go to the wayside. And Emory Healthcare is in the midst of a really exciting transformational change. We have Emory Digital that's doing great things. We partner very closely with digital. HR is reinvesting into our frontline. We're partnering closely with them. And so we need all of you, right, to make sure that this happens and that we continue to be a leader in transformation. So I will end there and take any questions. I think we have a few minutes.
We do. Thank you so much for such a wonderful presentation and for giving us such a nice summary of where you started, why all of this work matters, and where we are headed with all of this stuff, all of this exciting stuff. I would love to ask a question that really dovetails nicely on your last conclusion. I think in our department, we have exceptional faculty, staff, learners who are really excited about transformational change, and also who want to be involved in existing initiatives, who may want to be involved in suggesting future initiatives. So how best do you recommend that we engage with your office's efforts? How do we do that?
Yeah, that's a great question. Because I need help, but if I open the floodgates, right, I want to be able to respond to
Right.
people in a timely manner. I think, so we're coming up with multiple ways to communicate what transformation is doing. We're going to have a newsletter. There's transformation CTO office hours. And so maybe I can share that with the Department of Medicine. We have our transformation town halls open as well. And so this is where we're communicating our initiatives. We're asking for feedback. And so maybe those are the best venues for now: the office hours, the newsletter, and the town halls for people to get involved.
Sounds great. So we will get that information from you and put that in a future Department of Medicine newsletter. But agree, this is one of those where the floodgates could open, and we understand that we want to be sort of tailored and targeted with our efforts.
Correct.
We have a whole spread of different questions in the chat. I wonder if maybe we can focus first on some of the Emory Healthcare stuff. I think David Prop had a question about what is being done to reduce and manage incoming messages from patients to us, both providers and to support staff.
Great question. Great question. So this is another one where we're looking at a lot of AI tools to be able to respond efficiently to these messages. We have nursing colleagues. We're actually going to expand our nursing call line to help with it, to expand it significantly. So there'll be more personnel coming on board, as well as AI capabilities like bot capabilities to respond quickly to some of the low hanging fruit. Again, depending on what the content is, so the things that get triaged to you and your staff members are actually appropriate. Because I know a lot of those messages could go to different venues to help offset that burden.
Great. Another adjacent patient experience question. Are we working to improve availability of interpreters and to streamline patient care and customer service for our patients who cannot speak English?
100%. So Byron Hunter has those teams again disparately were sitting in patient experience shops. That is being moved to health equity. We are harmonizing those resources, those teams to be reporting up centrally, and we're also bringing in IT. That's another big epic project, is to bring in IT capabilities. Alistair Erskine wants to put videos in every single room, right? To make sure that those interpreters are available at least digitally everywhere. And then we also have our in-person teams that can help as well.
Thank you. And with 1 minute remaining, a tiny question that's a huge question, which is really are there other aspects of medical diagnosis that are unnecessarily factoring in race? And how can we be more aware to those issues so that we can begin to take more action?
Yes, that's a big question.
Yeah.
Yes, there are many algorithms that continue to have race, but the good news is that the societies are moving quickly to change that. I think there's this false kind of notion that like don't ever use race. No one is saying that. I think everyone's trying to be mindful that race can be helpful to advance health equity, right? COVID was a perfect example of that, making sure that we're targeting communities that have been underserved, that don't have access to information or access to resources, et cetera. At that population public health level, it's amazing. In biology or predicting biological outcomes, it's terrible. It should not be used. And so I think that's how you should look at it. If you see it used in a biological algorithm, number one, say something, right? Because I am definitely not aware of, I just learned about the Frax calculator in endocrinology. I'm not aware of all of them. But say something, raise that to your leadership, right? Why are we doing this? If there's a biological outcome tied to this race prediction, why are we using that? That's the first step.
Wonderful. Thank you so much for such a wide-ranging and thought-provoking talk, and thank you for all the work that you're doing to help us provide better care for our community. Thank you so much.
Thank you for having me. Take care.